All right, so we'll get started. Welcome everyone back to UCSF's Cardiology Grand Rounds. I'm honored to present today Dr. James Pirruccello. Dr. Pirruccello completed his cardiology fellowship at Massachusetts General Hospital before continuing on as an instructor and subsequently being recruited here at UCSF as an assistant professor. His clinical and research interests lie in the prevention of cardiac and aortic diseases. He uses machine learning to develop novel quantitative cardiovascular traits and studies the genetic basis of these traits. He has extensively published in these research areas and completed a postdoctoral fellowship in the labs of Dr. Sekar Kethiresan and Dr. Patrick Eleanor at Massachusetts General Hospital. He has been awarded a K08 grant from the NIH to support his current research, and his prior research awards include the John S. Ledoux Memorial Fellowship Award from Harvard Medical School and a Sarnoff Cardiovascular Research Foundation Scholar Award. With that, Dr. Pirruccello, welcome. I'm very excited to hear your talk, and I'll hand it over to you.
Awesome. Fantastic. Thank you so much for the warm introduction. It's exciting to be talking here at UCSF. And I'm just going to get started because I only have 130 slides to get through, no problem. I am trying to structure this to help people sort of see aortic disease from the same vantage point that I see it. So I'm starting with basically like what are complex traits, and then working down to what are the influences on aortic diameter, what even is a large aortic diameter, and then we don't screen for ascending aortic disease, should we? The reason that any of this matters clinically is because aortic dissection is an important cause of morbidity and mortality in the United States. Even in the COVID era, it's still the 18th leading cause of death in older adults over the age of 55. Much of the insight that we have into aortic disease comes from familial syndromes and also from the International Registry for Aortic Dissection, which is called IRAD. And from IRAD, we can see that about 5% of people with aortic dissection have Marfan syndrome, and the other familial causes of dissection are less common. And this is a pretty small fraction of overall aortic dissection. And I will argue that these familial causes are critically important for giving us insight into the disease, but not ever going to be the explanation for everyone who has aortic dissection. And this is because aortic disease is a complex disease. It is a polygenic disorder. And to get at the meaning of what is a complex trait, the complex trait is any phenotype that doesn't exhibit classic Mendelian inheritance that is attributable to a single locus, which is virtually every disease in humans. And how do we study complex disease? Mostly in the current era through GWAS, genome-wide association studies. So as an example, I'm showing you a GWAS of lipid levels from 10 years ago, showing Manhattan plots. So the x-axis is chromosomal position, y-axis is a negative log 10 p-value, and we identify loci in the genome that are associated with lipid levels. And Kiran Musunuru took one of those loci, in fact, the precise SNP RS127403774, and demonstrated that it was causal for changes in cholesterol levels by modulating expression of SORT1, which encodes sortilin. So it can teach us biology if we can do the downstream investigations. So maybe you're thinking, great, someone should do a genome-wide association study of aortic dissection. And Diana Milowitz beat you to it by 7 years. So she is chair at Texas. She and her colleagues put together a genome-wide association study in 750 cases of aortic dissection, 2,250 controls, and they identified 3 loci. They sort of undersold their paper in their title, but I will give them back the third locus because it's an important one, FPN1, which is the locus harboring fibrillin, which is the causal gene for Marfan syndrome. So this, to me, is a critical work because it shows that aortic dissection is a common complex disease. So that's checkbox number 1. So then 3 loci is a very important start, but there's not that much biology to get when you have so little to work with. So how do you improve your power to make more discoveries for aortic disease? Well, very obviously, you can increase your sample size, but that is usually easier said than done. Their study had 750 cases, which is about 10% of the entire IRAD registry. So imagine if you take coronary disease and you in your study get genetic data on 10% of all people who have ever been known to have coronary disease. That would be a massive study. So it's simply the case that the number of people who have been identified with dissection is simply much smaller. So getting a larger sample size would be a very difficult way to go about this problem. It's a good thing to do, and we ought to be doing it, but that is going to be work that takes a long time.
I thought there was a way.
The other approach, and the one that I'm going to favor, is to try to gain statistical power by studying quantitative traits in healthy people, but that relies on some critical assumptions. The first assumption is that the phenotype that you're studying is actually on the pathway to disease. And the second is that variation in healthy people is informative for disease. Just to sort of be concrete about it, if normal variation in healthy adults in aortic diameter is unrelated to their risk of dissection, then you could study it all day long and it will teach you nothing. So let's test the hypothesis. The reason to think that diameter should be relevant for aortic dissection is because tension in the aortic wall is proportional to diameter and blood pressure, and inversely proportional to wall thickness and other wall properties. And so in order to try to study this at scale, we had to think about what is a place where we can find many people with genetic data and the ability, at least, to measure aortic diameter. I think, current best place to do that is UK Biobank. For those not familiar with it, it's a prospective study of 500,000 people in the UK. They were aged 40 to 70 at enrollment. They all have genetic data and then clinical data, including ICD codes and procedural codes, and then enrollment lab data was obtained for everyone. And then in 100,000 people, they are undergoing an imaging study using MRI. What is unique about this resource is that the imaging is done for research purposes only. There is no confounding by indication. So just to orient you to the images that we were studying, this is the aortic distensibility view. The person is lying on their back, their feet are coming out of the screen towards you, head is going into the screen. The right pulmonary artery is crossing the screen at a 45-degree angle. Above that is the ascending aorta, below that is the descending. So there are 5 million images that we analyze because the cardiac cycle is chopped into 100 time points per person. You could just take one, but if you really want to capture the aorta at its maximum diameter and minimum diameter during the cardiac cycle, you really need to measure everything. So 5 million images would be a lot to do by hand. And so at some point, you're going to end up using machine learning, whether you're using a classical approach or a more common modern approach like deep learning. And so that is what we did. There are many ways that you could do this. The approach that I favor, which is model independent, but just the way that you set up your task, is semantic segmentation, which is the process of applying a label to every pixel on the screen. And I think about it like this. So you can train a model to perform regression for you. And we could feed in the images from cardiac MRI to a deep learning model and ask it to tell us the diameter. The problem is when it's wrong, because we can verify if it's correct or not. We can look at the output, we can measure it ourselves and then say, yep, the model is right, note the model is wrong. But when it's wrong, we have very little insight into what went wrong. And in contrast, when the approach is semantic segmentation, we are basically producing these pixel level maps, and then we're doing a final post-processing step that doesn't use machine learning to extract the diameter. And so when the model is wrong, when it has placed aortic pixels in some other location, we can troubleshoot and understand more about how to fix that problem in the future. It doesn't open up the black box. I mean, what happens inside of these models doesn't need to be understood from my perspective, as long as you can troubleshoot the output. So I do a lot of semantic segmentation, so much so that I wrote a tool to be able to do this. I actually sit there on an iPad. So like I'm buying iPads and the university's, looking at me sideways saying, what are you doing with that? But it is actually to use the pencil to annotate training data for semantic segmentation. So this is like an actual example from one of my prior papers of training input. And then you accumulate enough of those training samples and you can train a deep learning model. The aorta is a circle in this view. So it is not a very complicated task to train a computer to perform semantic segmentation. And what I'm showing you here, x-axis is the number of training images. So this sort of paired raw image and then the manually annotated label. And then the y-axis is the accuracy of pixel labeling for the aorta. And so really, once you get above 100 training examples, the model will perform just fine. So this is just demonstrating deep learning output, colored red for the ascending aorta and yellow for the descending. And to be very specific, because I'll be making some clinical commentary later on in the talk, I am measuring the aortic blood pool diameter during its largest point in the cardiac cycle when it's maximally filled with blood, but also on the minor elliptical axis. And this is because, since this is an automated study, I'm not reviewing all 50,000 imaging sets. And so you can falsely elongate if you haven't perfectly lined up your imaging axis, but you can't falsely foreshorten as long as you've captured the entire aorta. So that's the rationale for using the minor elliptical axis. So when we perform semantic segmentation in the UK Biobank and then extract those diameters, this is a distribution that we see, and I'll go into more detail about the actual numbers and cutoffs, but I wanted to just highlight this shoulder off to the right with ascending aortic diameter greater than 5 or 6 centimeters. And the question is, are those real, or is that just, problems with the model? And highlighting the deep learning output here, we see that the ascending aorta for this particular person is larger than their vertebrae, right? So this is truly a large ascending aorta. It's compressing the right pulmonary artery. And I think reassuring when we look at all the large aortas on that shoulder, that these are not simply model error. These are actually people with big ascending aortas. So we can bring that forward for genetic analysis. I'm not going to spend much time on this because it's not my focus today, but in this analysis, we first ask, what is the heritability, or what is the proportion of variation in aortic diameter that is attributable to the variance that we see in the genotyping chip? And the heritability is quite high. It's over 60%. And when we then bring that forward for a genome-wide association study, and again, x-axis here is the chromosome in position, y-axis is negative log 10 of the p-value, we identified 82 loci that were associated with ascending aortic diameter. When we do the same thing with descending aortic diameter, we see a slightly lower heritability, and we identify 47 loci. And just to highlight a couple points, one is some of these loci are quite biologically plausible. For example, elastin.
I get an email that's War and Peace.
It is War and Peace. Elastin, which makes up 40% of the aorta by bulk mass, is one of the loci. And then fibrillin, FBN1, is another. And in fact, sort of digging deeper into that, all of the loci that have previously been identified by Dr. Milowitz and her colleagues as being associated with aortic dissection are also associated here with aortic diameter. So biologically, that's not surprising. We, I think, expect that things that make aortic diameter larger also predispose to dissection, but it didn't have to be true. it could have been the case that those genetic drivers are orthogonal to each other. So I think it's pretty reassuring that we see that the same loci come up here as well. So thinking about risk factors, causal inference would be a very nice thing to be able to do, asking what causes an enlarged aorta. And genetics is nice here because genetics does have a privileged position in terms of correlation interpretation, which is just to say, if you find a correlation between a genetic variant and a phenotype, it is not necessarily the case that the genetic variant is causing the phenotype. There are many ways in which it can be associated without being causal, but you can be certain that the phenotype is not causing the genetic variant. And so here, Mendelian randomization is a technique that is used to create a genetic approximation of let's say a biomarker, or in this case, blood pressure, and use that to try to understand its causal effect on an outcome, or in this case, aortic diameter. And it relies on some assumptions. For example, it relies on your ability to either assume or to test whether those genetic variants are associated with other pathways that could be causal. For example, at the bottom, I'm just showing, does that genetic variant change cholesterol levels, for example? And it also relies on the genetic variant not directly modifying the outcome of interest. So if the genetic variant somehow directly modifies aortic diameter, then the fact that it's also associated with blood pressure is irrelevant. So after making those assumptions, you can test some, but otherwise it's a process of belief. We can look at questions like, is blood pressure causal for ascending aortic diameter? And for those of you who do epidemiology, you might look at this chart and say like, wow, that is incredibly ugly. I can't believe you're drawing lines through that. For those of you who do genetics, you might look at this and say like, wow, that's one of the strongest Mendelian randomizations I've ever seen. So this is a GWAS of diastolic blood pressure in about 400,000 people. And we see that diastolic blood pressure by any of the Mendelian randomization approaches is causal for an enlarged ascending aortic diameter. And a UCSF staff, so Dr. Thianju was at Stanford, and she and I have been doing sort of parallel work, and hopefully we'll start doing work together now that we're both here at UCSF. So I'm very excited about that. And she and her colleagues formalized this observation into a manuscript that was just published at the end of last year, looking at diastolic blood pressure and ascending thoracic aortic diameter. So I will also just make some commentary about other potential risk factors. Here, I'm looking at ApoB. Also, the GWAS for ApoB is in about 400,000 people. These SNPs explain 20% of variation in LDL cholesterol. So this is not a weak GWAS of ApoB. This is a very powerful GWAS. And yet, there is no association here between ApoB and ascending aortic diameter. And we see the same thing for lipoprotein a. There are a bunch of SNPs listed here, but something like 60% of variation in lipoprotein a is driven by one causal variant. And that's the variant way off to the right on the screen. And so there's no association either between lipoprotein a and ascending aortic diameter. So this is sort of just the beginning of thinking through causally the association between putative risk factors and ascending aortic diameter. There are a bunch of other efforts like this that are ongoing, but since this is being live streamed, I'm not going to put this out there just yet. So if there are folks who are interested, please talk to me offline. And then you can do things like produce polygenic scores. So this is a polygenic score that is a genetic estimator of ascending aortic diameter. When you include that genetic estimate in a model that tries to predict who's going to develop a need for thoracic aortic procedures, we see that the score has a hazard ratio of 1.6 And we strongly reject the null hypothesis that there's no association between that score and the outcome. Or if we look at just the top 10%, those folks have a twofold hazard of requiring thoracic aortic procedures compared to the middle 80%. So this is just to say that I think there's a lot of evidence that we're studying a relevant phenotype that's on the pathway to outcomes of interest. And it certainly seems to be the case that variation in aortic diameter in healthy people is relevant for aortic disease. So then, like, kind of back to the very basic question of what is a large ascending aortic diameter? I think actually the 2022 AHA guidelines for aortic disease are extremely well written and easy to read and helpful and informative. So there are, I think for the first time, there's clear language around what is enlargement. So 4 centimeter threshold for aortic enlargement. Aneurysm, you can start to apply the term at 4.5 centimeters. And then the guidelines tell us when to consider surgical intervention. So 5.5 centimeters for all comers is class 1 indication. 5 centimeters in high volume centers is a class 2 indication. There are also special carve outs for folks who have genetically mediated aortic disease, such as Marfan syndrome, Marfan syndrome with risk enhancers, or non-Marfan genetic aortopathies. So you could say, I would only like to find people who have either 5 centimeter aortic diameters or maybe 4.5. I would just argue that you'd probably like to identify people before they get to that precipice. So to me, that 4 centimeter threshold of enlargement is probably the most interesting cutoff that we can put together. There are a few reasons for that, not just our guidelines, but also if we look back at the IRAD database of people who have had aortic dissection, the vast majority of people in that database had a diameter greater than 4 centimeters at the time of dissection. Or if we look at the MGH experience, we see that as ascending aortic diameter increases from 4 centimeters up to 5.5, the incidence over 5 years of it, in this slide showing the incidence of undergoing aortic surgery climbs above 50%. Now, obviously there's a limitation here, which is who decides when to take someone for surgery? Well, outside of emergencies, we decide, we make a choice, we discuss with the surgeons, and we recommend to the patient that they undergo surgery. So this is like not an external event. This is our decision. We could make this number anything we want. We could convince people with a 4 centimeter aortic diameter to undergo surgery if we wanted to do that. So I think that's a real limitation. Having said that, they also looked at dissection or rupture as a function of aortic diameter. Now, this is very limited. The hard part here is that we are now following these patients, and most of those people, more than half of the people with aortic diameter greater than 55 millimeters underwent surgery within that 5-year window. So you're getting rid of much of the denominator and presumably much of the numerator by taking them to surgery. Just at the end of last year, Kaiser published their experience as well. These are modeled 5-year risks of dissection based on thoracic aortic diameter. So the risk at 4 centimeters is pretty low. And that risk climbs as the aortic diameter increases, and finally above 6 centimeters, we're looking at a greater than 10% risk of dissection over the course of 5 years. So I think from a diameter standpoint, that 4.5 centimeter threshold is certainly interesting to consider where risk starts to rise, but identifying these people probably around 4 centimeters would be ideal. So this brings me to the last set of points that I want to make, which is we don't screen for enlarged thoracic aortas. And I think the questions are, could we and should we? And maybe taking a step back, do we need to? Are we already incidentally finding most people who have an enlarged ascending aortic diameter? It could be happening. right? Like people could get imaging for some other purpose and their enlarged aortic diameter could be discovered. Or maybe cascade screening is so effective that we are capturing the vast majority of people with enlarged aortas. And so additional screening programs aren't even needed. What is particularly helpful, I think, for this question about UK Biobank is that the imaging done there was, again, without any clinical indication. So we are not biased by, who came to our referral center because of aortic disease. And so now our image database is populated by people who were referred in for this problem. We're looking at people who, the main bias is just healthy volunteer bias. And so in the UK Biobank, here I'm showing you 30,000 people in a training set for a model developing exercise. We see that the 95% cutoff of aortic diameter is 3.8 centimeters. And if we split that out into men and women, the 95% cutoff for women is 3.6 centimeters, and the 95% cutoff for men is 3.9. So using that 4 centimeter threshold, what fraction of the 700 people in the UK Biobank with an ascending aortic diameter greater than 4 centimeters were already given a label, either because they'd undergone surgery or because they had an ICD code applied to them? And that number is 2 out of 700 people with diameter greater than 4 centimeters who had an aneurysm label before MRI. And you might, I think, very appropriately say, well, 4 centimeters is enlarged, but it's not aneurysmal, so it's appropriate that they did not have an aneurysm label. But if you look at the 45 people who had diameter greater than 4.5 centimeters, none of them had a clinical label of aortic aneurysm. So, certainly there are limits in the UK Biobank, but I think that this at least gives us a sense that many people with aortic diameter that is aneurysmal are not being detected by our current approach, which is, it's not systematic at all. So there's been interest because of that in developing clinical models to identify people who may have an enlarged aorta. So the idea here is you predict who's going to have a big diameter, and then downstream use that prediction to bring them in and perform imaging to confirm whether or not their diameter is large. So Obel et al. Built a model based on age, sex, and body surface area. Mori et al. Built a more complex model. But you'll notice the things that I underlined here: arrhythmia, aortic valve disease, family history of aneurysm. And I think, I'm a little bit cautious about that type of model, because if you have a model that requires family history of aneurysm as its input or arrhythmia as its input, those people already have an indication for imaging. So I would argue that you don't need a clinical prediction model, because you're going to get images. And once you have images, just measure the aorta. You don't need to predict it. So taking advantage of the unbiased nature of the UK Biobank's imaging protocol, we developed a clinical prediction model as well. So we took 30,000 people with MRI measurements and built a score, which is a simple linear model based on a few predictors. So age and sex, and then variables that are commonly measured in a clinic visit. So these are intentionally selected by me and Mark Lindsay, sitting around one evening thinking about, like, realistically, what do we get in a clinic? We get blood pressure, height, weight, BMI, heart rate. And then easy questions to answer: do you personally have a history of diabetes, hypertension, or high cholesterol? And so those are all the predictors in the model. The model itself is a hierarchical group lasso. And that sounds fancy, but it is a simple linear model. Lasso just means that it's penalizing the absolute value of the weights of each factor in the model. And hierarchical group just means that we're allowing the predictors to have interactions with one another. And the hierarchical component just means that the model is not allowed to construct itself in such a way that you have interaction terms without the main terms. So if there's an interaction between age and sex, then the model will always also include the main age term and the main sex term. So the model, which does both fitting and term selection at the same time, retained all the 11 terms from the main input features, and then also 29 interaction terms. And to try to give some insight into how that behaves, I'm showing you here the performance of that model compared to an age and sex model in 3,000 held out UK Biobank participants. So basically an internal validation set that was not part of the subset of participants used for model training. And so in the bottom, the age and sex model, the x-axis here is the predicted aortic diameter based on the model. The y-axis is the true diameter. And one thing that I think immediately stands out is that there is a separation between men and women. In other words, there is no woman who has an aortic diameter prediction that is as large as the man with the smallest aortic diameter prediction. So the age and sex model explains 18% of the variation in aortic diameter. When we get to the aorta score, which is that hierarchical group lasso-based score, we now explain 28% of the variance. And I think reassuringly, we see that there is overlap now between the largest predictions for women and the smallest predictions for men. So there's some bias that is eliminated. By that, I mean, if you remind yourself of the actual aortic diameter histograms for men and women, they are very similar. Sure, men are shifted to the right, but a model that predicts that the woman with the largest aortic diameter is smaller than the man with the smallest is nowhere near where it should be performing. So I think that is reassuring to see. And then also, if we look at the predictions at the extremes, not that these are extremes by any means, but at the extremes of the prediction itself, we see that the aorta score is able to give us a more broad dynamic range of predictions. If we then apply these predictions to everyone in that test set and then group them into 5% buckets, we can then ask what fraction of people in that bucket have aortic diameter greater than 4 centimeters. The red dashed line is the population average. And so the age and sex model here, focusing in particular on the people at the very high end of the score, that highest end group has 5% with aortic diameter greater than 4 centimeters. And so by adding those clinical variables that, again, I think we get in clinic routinely, so there's not additional work to get this information, it's just adding them into the model, we see that 7.5% of the people in the top bucket have diameter greater than 4 centimeters. The other thing worth noting is that the bottom 20% are aneurysm free. None of those people have aortic diameter greater than 4 centimeters. Or if we formalize this in an ROC curve, so this is using the continuous score, in other words, the prediction of aortic diameter as the input, and we're trying to predict diameter greater than or equal to 4 centimeters. The aorta score here is depicted in red, which has an AUROC of 0.77, and that is superior to both the age and sex score, and then a Cox model that I really didn't talk about at all, derived from predicting diagnoses or surgical procedures for aortopathy. And so that's all well and good, but I think you can really get yourself tripped up by only using the UK Biobank. So we tried to bring this externally. So the UK Biobank uses MRI. We brought this to Framingham Heart Study, where about 1,400 people had computed tomography. And interestingly, the AUROC was higher in Framingham. And you might say, that should make you skeptical or wonder if there's an error. But the trick to computed tomography in Framingham is that it is non-contrast. And so unlike our study where we are measuring the blood pool, in Framingham, you're including the walls. And so the aortic diameter measurements in Framingham are much larger. Because the model is imperfect and because it is mostly making predictions in the smaller range, if you just shift everyone up to a larger diameter, our model is now in a range where it's performing well. So that type of systematic bias in Framingham makes the model look great. And then we looked at echocardiography at Mass General, and we found a very similar AUROC to what we found in the validation set in the UK Biobank. And so then we can bring that score forward and say, like, what would this look like if we decided to use this for screening? So for screening, you would never simply refer someone to surgery, for example, based on a prediction of aortic diameter, when you could put a probe to their chest for 2 minutes and measure it. So I imagine that screening, if it ever is a thing that we decide to do, will be used as follows. You will create a threshold above which you decide to bring people forward for imaging. So here I am simulating a low cutoff. And the way I did that was in the training set, so an overfit set, I took the 90th percentile of people with diameter greater than 4 centimeters. So basically I ignore everyone with a smaller diameter, take the people with 4 centimeter diameters, and then that bottom 10% I know I'm going to miss, but my threshold is that bottom 90th percentile, and then bring that forward into the validation set and apply that same threshold without modifying it, because we can't look. You know, when you're applying this in a health system, you're just going to have to know what the right threshold is. And then ask what would happen if we brought those people forward for imaging. So what we find with that threshold is that we would be imaging 45% of the population, and we would identify about 90% of people with diameter greater than 4 centimeters. So we would identify, in this case, 138 out of 158 people with diameter greater than 4 centimeters. Imaging 45% of the populations may not be feasible. So the other extreme of like a principled approach to creating these cutoffs for this type of paper is we know that 2% of the population in this study had diameter greater than or equal to 4 centimeters. So let's say that's the bare minimum number of people that we would ever need to image in order to capture all people with diameter greater than or equal to 4 centimeters. And if we apply that threshold, then we see that 9% of people above the cutoff have diameter greater than or equal to 4 centimeters, and we're capturing about 9% as well. So how does that look compared to aortic, like abdominal aortic aneurysm screening? It's hard to find exact numbers. So abdominal aortic aneurysm screening basically applies to men who are ever smokers over the age of 65. And so I ballpark that at about 7.5% of the population, where we would say that they have an indication for screening. And the experience that has been published for the number needed to image to find an aneurysm is 15. So if we use the aorta score at that low threshold, where we're imaging 45% of the population, we would need to image about 23 people to find one with a large aortic diameter. Or if we use the high threshold, where we're saying, you know, I don't want to comprehensively understand everyone who has a large aorta, I just want to find some people who have a big aorta for my study. Then you're only imaging 2% of the population, and 1 out of every 10 is going to have an enlarged aorta. So I think that there's something in between that may give us numbers that are similar to abdominal aortic aneurysm. It's really important to say that this portion of the study is just a simulation, and in fact, essentially added because reviewers wanted to see it. But the thresholds would depend on a lot of factors, including cost. This is not something that you just do in isolation. This is an economic decision that either a health system or that we as a society would make. And so in order to understand the flip side of that cost, we would need to understand benefit. So I think that this is a long way from actually being implemented in the clinic, which is good and bad. I think it's good because it gives us some work to do clinically, from a research standpoint. But if you're hoping that this is like something that you can just immediately deploy, I wouldn't recommend it. You can still estimate your own aortic diameter. We have a website where you can do that. But the actual clinical utility of this remains unknown. So at the end here, I just want to say that some of these, there are questions that are important that we really can't answer from the work that I've done so far. So, the aortic score explains 28% of the variance in aortic diameter. Is that good? How much could we predict? I guess I would argue that since we know that the heritability is 60%, and I will tell you that the aortic score is uncorrelated with the polygenic risk score, in principle, this means that the aortic score is telling us about environmental factors that predispose to your risk of enlarged aorta. Obviously, some of those factors have genetic components. So like blood pressure is not just environmental. So it is probably the case that as our sample size grows, we will find that there's some correlation between the aortic score and the polygenic score. But if it holds up that there's no correlation, we would be able to explain up to 88% of the variance if we had a perfect polygenic score. So certainly the number is going to be less than that. There's no human trait aside from height that has a polygenic score that is powerful enough to do that. But I think that this gives us a sense, or hopefully gives you the sense, for why I'm so interested in polygenic risk, in particular for aortopathy. It's not true for every disease. This is a very high heritability. So aortic disease is special in that way. But I think that there's a lot to be learned by trying to develop better polygenic scores for aortic disease. And then I think the key clinical question is just, is aortic dissection risk a function of absolute diameter? Or is it more a function of, sex or height index values, body surface area index values? Should we be, residualizing for the aorta score? So is your risk of dissection simply a function of the diameter without any modification? Or is it how much, difference, how much delta from your aorta score prediction your diameter is that tells us what your dissection risk is? And I can tell you, I certainly cannot answer that question in the UK Biobank because for privacy reasons, I will just say far fewer than 20 people out of the 60,000 who have undergone imaging have had a dissection. So this is not the place to answer that question, but I think answering that question is very important because it would influence how we report out the aortic diameter on even just clinical echocardiography, or how we think about when to refer people to surgery. So this is an open and important question that is not answered in this work. And I think very clearly, if we look at animal biology here, so this is a blue whale's heart, and there's a big white plug in its aorta. So clearly, aortic diameter alone is not the only thing that matters for dissection risk. Otherwise, all blue whales would just dissect at birth. So there's something else going on. It's properties of the wall, but maybe things beyond that. And so I think getting a better handle on the non-diameter properties of aorta is important. So to conclude, thoracic aortic disease is heritable. It's a complex trait. So gene panels are never going to capture all the risk. Familial studies are not the final answer in aortic disease, although they are critical both for the families who carry them and for understanding the biology of the disease. Blood pressure, causal for ascending aortic diameter. Cholesterol does not appear to be causal for ascending aortic diameter. We're really not identifying people with large aortas clinically. We can predict people with some effectiveness, explaining 28% of the variance in aortic diameter, but it is still not clear whether there's any upside in trying to use that to bring people forward for imaging. That is work that needs to be done. UK Biobank is depleted for disease, which matters a lot. So if we look at the Kaiser experience again, they have thousands of people with ascending aortic diameter greater than 4 centimeters, something like 6,000. But they don't report the denominator. So I know that there are about 12 million people who use Kaiser. Presumably not all of them have had imaging, but there are limits to using clinical databases like this to try to understand healthy populations. There's limited follow-up time in the UK Biobank after imaging, which makes it difficult to make commentary about disease consequences of enlarged aortas on healthy people. And then just broadly, the risks and benefits of screening are not established. And I think the Dankovec experience in 10,000 unselected men who underwent imaging showed no benefit. Now, to me, the entire purpose of doing something like an aorta score is to avoid this process of performing imaging on unselected people. It's to actually select people who are going to be enriched for disease. So I'm not sure how relevant that is, but I think it's probably the most important study that's been done so far for imaging for primary prevention. So just to then blast through some recent aorta-related work, and particularly students and fellows, I hope you're watching. If my browser decides to be friendly. So just yesterday, we published a paper in JACC looking at aortic distensibility, so that sort of change in diameter during the cardiac cycle. And there, we actually do see strong links with atherosclerosis, which is quite different from the static diameter measurement. So it seems to be the case that athero does not manifest as narrowing of the aorta, but rather as restriction in its mobility. And then we found other links like TGF-beta and elastogenesis, which I think are already pretty well established. Working with a student in Patrick Eleanor's lab, Mahan Nikoi, we measured not just the ascending aorta, but also the aortic root. There are fun engineering challenges that go along with trying to get those measurements. Clinically, we found that the segment just above the sinus seems to be the segment that is the most important for predicting risk of aortic dissection. We also looked at sort of pairing the pulmonary artery and the ascending aorta. And there are some loci, particularly the TBX5, TBX3 locus, that appears to control the positioning of the septum. And so there's a little bit of tension between ascending aorta and the pulmonary artery diameter. And there's ongoing work. So one of the things that I promised to do in my K is to sort of do the same type of work throughout the entire aorta. So really mapping the aorta from root to bifurcation. I'm working with Shino Kani also in Patrick's lab, measuring the flow across the aortic valve. And so in collaboration here with Samuel Maria, we are sort of in hot pursuit of some findings there. And it also is just nice to look at valvular lesions on MRI. You can really visualize what the data are telling you. Here I'm showing you someone who has both stenosis and regurgitation across the aortic valve. And then really trying to map out the heart from all of the available data. And you can sort of see I do a lot of segmentation, and I think it's because it's not just something that you can use to perform measurement, but you can then also use that to say, take the heart, isolate it from the rest of the body, and now study it without having to wonder, oh, is my deep learning approach really just picking up on obesity or something about the bone structure? It's really allows you to isolate your analysis to just the structures of interest. And when you do that with orthogonal data, you can start to do things such as what I'm showing you here, which is reconstruction of a three-dimensional model of the left ventricle. So this is the type of work that I'm doing and would be excited to work with students, trainees, fellows, and other folks. So please come join. With that, I'll say thanks to Jeff, Greg Marcus, Samuel Maria, a talented medical student here, Siavash Zamirpour, Patrick Eleanor, Mark Lindsay, and all my friends and collaborators at MGH and Broad.
Thanks so much, Dr. Pirruccello. That was such a great talk on predicting aortic disease. So if anyone has questions in the audience, please raise your hand so we can call on you to ask. I did get a couple questions in the chat. So the first question is a more clinical question, which is just if there is an incidental note of an enlarged aorta on an echo, is it defensible to get CT as the next step as compared to MRI, which you mentioned is what the UK Biobank uses? How do you think about your next imaging study to order?
Yeah, so yes, in fact, I would say that CT is probably more common. For people who require lots of longitudinal imaging, sometimes we will alternate between CT and MR. But I don't necessarily have personally, I don't have a system. I like CT for its resolution. So I would probably favor starting there unless there's some reason not to. But if you do identify an enlarged ascending aorta, there is a strong correlation with finding other abnormalities, such as an enlarged descending aorta or abdominal aorta. So imaging the entire aorta is advised.
Great. And then the second question had to do with earlier you had shown the correlation between diastolic blood pressure and the size of the aorta. Had there been similar demonstration for systolic blood pressure, which may be a more clinically actionable measure, or pulse pressure?
Yes. So there are weaker associations with systolic blood pressure, and Dr. Tianju and her colleagues showed that pulse pressure does have a similar and strong association, but the statistically strongest evidence is for diastolic blood pressure, which I would argue should be pretty actionable as well. Easy to miss, like easy not to notice, but I think still worth acting on. There is also, I didn't show this, it's very painful to think about. There's bidirectional causality, which is to say that it appears to be the case that having a larger thoracic aorta is also causal for having a higher blood pressure. You can speculate as to why. So maybe it's the case that the arterioles have to remain clamped down to provide adequate coronary perfusion pressure for people who have truly large ascending aortas. But that would all be speculative. I'm not really sure why, but it's fun and maybe painful to think about.
Dr. Kaiser, you have your hand raised.
Hi, James. Very nice presentation. I was curious whether you've looked at or are at liberty to share whether the polygenic risk score does add to, or how much it adds to the AUC of the clinical risk score you presented, is my first question. And the second question is, are you also at liberty to share how Mendelian randomization analyses show diabetes to influence aortic diameter?
Yes. So for the first, that is work that's underway. It is a little bit more complicated just because of the difficulty in porting polygenic scores to external sets. Certainly within the UK Biobank, which is sort of like an easy playground, it adds another like 10% at current sample sizes to the variance. So we get from like 28% to 38% variance explained. The effect on AUC gets us, it depends on exactly how you set it up, but on the order of like 0.81 to 0.85, again, within the UK Biobank. Now, I think like that's all well and good, but it's hard to care about internal validation with polygenic scores. And so I'm in the process of getting that set up to test with some collaborators at MGH and trying to figure out if we can collaborate with Penn as well. So if there are folks here who are interested in trying to help test that anywhere else, that would be fantastic. And then the other question was about diabetes. There is a really weird observation there, which is that it decreases aortic diameter. And I actually don't remember if the causal analysis, the fundamental part of your question is about the causal analysis. I don't recall whether that is statistically significant, but polygenic scores and observational analyses are all consistent that greater propensity for diabetes seems to be associated with a smaller aortic diameter. I think the hard part for me is, aortic, you could imagine, let's just say that you get a porcelain aorta that's small. Well, it's probably still not protective against dissection. So I think that there is a fundamental limit in terms of our ability to use diameter by itself without sort of integrating more broadly information about aorta and its properties. But yes, it seems to be associated with a smaller diameter, which all other things being equal, should be protective against dissection. You can imagine, based on how I'm talking, that I doubt that smaller diameter due to increased risk for diabetes is protective, but I could be surprised.
And you brought up a fascinating point. Are you looking at calcification? Are you phenotyping calcification in your studies or not yet?
In this case, it is very difficult to do that because it's just MRI. There is some really creative work from Calico, which is a company in South San Francisco that basically mapped calcification that they can see from DEXA scans to the general vicinity of aorta to be able to make commentary about aortic calcification. But otherwise, at least with MRI, I think it's very difficult to do that.
Great. Any other questions for Dr. Pirruccello?
Yeah, Lyle, I have a question. Very nice talk, James. I enjoyed it. I noticed that you don't correct the diameters for size. I mean, it seems obvious that Peter Dinklage and Shaq O'Neal are going to have different sized aortas. And, maybe that explains the sex differences you showed. It's just a matter of size. So, and we don't do it routinely in the echo lab either. So are we missing the boat here? What do you think?
Yeah, I mean, I think that that's like one of the fundamental unanswered questions, because it, like, you could easily tell me two different things and I would believe either of them. One could be that actually women dissected a much smaller size. Or you could tell me that size is all that matters and very few women have dissections. And either of those biologically could be true. I certainly agree that you would imagine, at least for people who survive to adulthood, that if they are larger, the properties of their wall must support a bigger aorta. But I think that we need more than just like common sense. I think it would be useful to have actual parameters to understand, what is it that we should be reporting, which features are actually protective for people with large size and which are not. So I think we should have an answer to that. And I don't have a clear path to do that in the UK Biobank, but I think within university healthcare systems, we may be able to figure out the answer to that question. But it is like the fundamental question, I think.
Wonderful. Other questions for Dr. Pirruccello?
James, I have a quick question. Is Ian here?
Hey, Ian.
Hi, nice talk. Really great ongoing work. I was surprised to not see health-related behaviors like smoking in your clinical model. And how do you think about those modifiable risk factors that may affect these polygenic risk scores? I'll give you an extreme example. I wouldn't be surprised if something like Mendelian randomization picked up nicotine dependence gene as causal for aortic aneurysm dissection. So how do you think about that?
Yeah, that's a great point. I intentionally left out those behaviors because I find them very difficult to quantify in clinic. Pack years might be easy enough, but like other behaviors like drinking, I think are difficult to get a uniform handle on. So that was a sort of intentional decision on my part, but I think it's a useful thing to think about for future work. And
I was going to interrupt you, but it's so critically important. One could argue it has potentially as big of an impact as some of these other factors, even though it's difficult to quantify. We know humans are humans and they do these kinds of things, right? Yeah.
Totally. Yeah, I think my expectation, based on what I've seen in the UK Biobank, is that those will matter more for, or at least I believe that they will matter for dissection risk. they don't seem to have a strong effect on diameter. But it sort of makes sense that those things could modify the properties of the wall in a way that may not manifest as an enlarged diameter, but may make you at higher risk for dissection. And that's something that I'm really not in the position to assess in this data set because of how little dissection there really is in the UK Biobank imaging cohort. So I agree. I think, being able to add that information in is going to be dependent on having a population where you can build a model that looks at dissection more than diameter, though. Mendelian randomization with smoking is tricky. In my hands, I have not seen associations, like causal associations between smoking and diameter. But again, I think, the more interesting question, for all of this, I mean, diameter is a proxy for dissection risk. If we had the ability to just study dissection directly, I would do that. But I expect, just like you're saying, that these factors will matter for risk for dissection, even though I can't show that they're associated with diameter.
Great. Thank you. And one last point I'll make, which is your work got me thinking about some of our work where perhaps some of the answers are in what's missing in these data sets, such as the most lethal aneurysms that kill people that never would have made it to get imaged, right? And there's so many, and that's essentially the data we're collecting, and many different phenotypes, but maybe we can talk some more about leveraging that.
Yeah, that'd be fantastic. I mean, I totally agree. By the time you're in the UK Biobank, you have survived by definition to age 40. And so that population is depleted for people with important high penetrance, like, for example, rare variation, or even just extremes of polygenic variation, which may or may not exist, that predispose you to a large aorta. Like, all of that will manifest at an earlier age than 40. And so, yeah, that is not going to be detected in the UK Biobank. So I agree. I'm very interested in figuring out how we can work together. Thanks, Ian.
All right, fantastic. Well, thanks so much again, Dr. Pirruccello, for speaking with us today. And thanks to everybody who asked a question. We'll see you next week.
Thank you.